Good. Okay, welcome everybody to our COVID question time. We don't have any theme music to sort of bring us in, but thank you ever so much for coming. We were expecting 13, so not everybody's arrived as yet. They may arrive a bit later, but welcome to everybody that's come, and a special welcome to Dr Ganguli, who's given up his time to answer some questions this evening. My name is Dave. I'm chair of Community Connectors. If you haven't heard of Community Connectors, we're a local group made up of people from the different faith groups and different organisations within our community. And we were set up a couple of years ago, and our main aim is to address loneliness and social isolation. And we do that by taking people's ideas of how to reduce loneliness, and then we work with them to make those ideas happen. So for example, one person had an idea about bringing young mums with babies together with older women, two groups of people that often experience loneliness. And we were able to run a group in Judd House, and a weekly group. Had to stop once COVID came, but that was an example of where we didn't actually cost us anything, because we were using Judd House, and the people came from both those groups and met regularly. It was a nice group. So that's the kind of thing that we do. But we've also received some funding from the council to promote the uptake of vaccines and to try and pass on public health messages to the community. We've had people doing surveys. You may have seen some of our volunteers going out doing our one question survey, and we've passed all that data back to the council to pass on to public health to inform their public health campaigns. But this evening, as I said, we're really pleased to have well-respected local GP, Dr Ganguli, with us, and we're going to ask some questions. Just a few comments about ground rules. We all know the importance of respect, and so I ask that even if you disagree with what anybody else is saying, let's disagree well and disagree respectfully. Also, let's be careful about confidentiality. If you're talking about somebody else you know, please don't mention their name unless you've got their permission to do so. Obviously, we have a zero tolerance on racism and abuse, and we have the facility to remove you from the Zoom room, the power. So well, I'm sure we won't need to do that, but it's just a safeguard really for everybody. And finally, Dr Ganguli is not able to answer any personal questions about our health needs or about our grandmother's arthritic knee. He's not able to do, I know it's disappointing, isn't it, Andy? So obviously he can't do that this evening. You have to make an appointment if you want to do that, but he will be able to talk in general terms about COVID. So let's begin with the first question. We know, Dr Ganguli, from the surveys that our volunteers have been doing, that not everyone understands how the vaccine works. Can you briefly explain to us, in layman's terms, how the vaccine works in our bodies?
Okay, doing a brief history, the vaccine actually came from, and it was discovered by Edward Jenner, and the first vaccine human used was for smallpox. It was identified that when you are affected by a particular disease, or you get mild form of a disease or similar type, then when you get that disease later on, a lot of the times you are actually not having similar amount of response or illness, and it becomes quite milder, or you might not get it. And that concept actually came on further to develop the vaccines. So I'm not going into the intricacies of the vaccination, how it's being prepared, but in a simple term, if you think of each and individual bug has an individual type of arm, you have to sort of use a particular type of ammunition to kill them, or sort of eliminate them from your body. And once you get that particular bug in your system, there are some cells in your body, which actually are your defense cells, works on with that particular bug to prepare itself to eliminate them from your system. Now, in vaccination, when we are preparing the vaccine, we don't use the particular disease element or germs itself. We use most of the time a protein which is similar to it, and we make sure that gets into our body, doesn't cause much harm, but actually makes it prime to make sure that in future, if similar bugs actually comes in, then the body is used to fight it. It's like a mock fight when you can actually prepare, when our armies prepare for themselves, so that when they're in the battlefield, they can actually fight properly. There are different types of vaccine works in a different way, but I'm not going into those intricacies. Some of them are using the empty cell for the bug. Some uses the protein itself, and the new ways of RNA vaccine actually uses the genetic material of the vaccine, which gets into your system and then produces the protein which is needed. But looking at simple way, this is actually trying to prime your immune system or your defense mechanism, so that if you actually get that bug, your body is prepared to fight it away.
Great, thank you. That was really helpful explanation. And if you've got a question, either related to what Dr. Ganguli said or another issue relating to COVID or vaccination, please, you can type it in, and then I can ask Dr. Ganguli that question. So I've got a few set questions, but it'd be great to have some questions from other people as well. So Dr. Ganguli, lots of people are concerned about this new strain, the Delta strain. Are all the vaccines effective against this strain?
Okay, fortunately enough, we have a very good research team in the UK, and they have actually done some preliminary research, and there has usually, when we were looking at the previous strains, one vaccine was quite effective, up to 60% to 70% effective, but for Delta strain, one vaccine is about 33% effective. And if you had two vaccines, then that is going from ranging from 70 to 90% effectivity. So if you actually have two vaccines taken already, then you are in a better position to avoid Delta strain infection. And the most important part I would like to stress on here is that if you do get the infection, then actually the disease process is quite mild, and there is significant drop in hospital admission, up to 98% in normal strain and about 90% in Delta strain from the complications and hospital admission. There has been a significant drop. So I think that sort of tells itself, the statistics.
Yeah, yeah. So 90%, that's high, isn't it? For any vaccine, would that be considered to be a high?
Yeah, I think
Yeah.
I think the main important part is the complication, which is mostly stressed. There had been different vaccines. The Pfizer had claimed to be around 80 to 85%. Moderna is hovering around 85 to 90 around, and AstraZeneca was around 70 to 75% effective against Delta strain. And that's again after two vaccines, but 33% is only for one vaccine of AstraZeneca. So I think that sort of reiterates the fact that we need to have two vaccines.
Yeah, I was just going to say that's evidence we need to make sure we get double vaccinated. Yeah.
And
there's a question here from Andy. Is there an incubation period for COVID?
Yeah, COVID, we say in from spreading wise, almost reacts like flu vaccine, flu itself. So I would say it varies from incubation has been sort of searched quite a bit, and it can be from 72 hours to up to 14 days, but very rarely 14 days. Usually within 3 days, you would be getting the symptoms of exposure.
But it could be longer than that.
Yeah, because obviously nobody's working on incubation at the moment, but on the previous studies which had been done, there had been sort of, that's why when we tried to initially think of isolation, it was 14 days initially, and then it sort of come down to 10 days.
Right.
But it can be a late presentation, but usually I would say within 3 to 5 days, you would be getting the infection.
Right. Okay, thank you. Obviously, you know, we're getting concerned about those who are choosing not to get vaccinated. We recognise that people have a choice about getting vaccinated, but is there a danger that those who are not vaccinated could become a pool for new variants to flourish?
Yes, I know it sounds terrible, but what happens is that we all know that a lot of 1 in 3, some studies saying 1 in 5 is asymptomatic. And if you are actually hovering the virus in someone, then they can actually combine and change their genetic structure, and they can become more virulent. And that's what all the viruses do. And that's why, and funny thing is that the transmissibility is reduced. There hasn't been a clear study that how much it reduces, but they have said that the transmissibility reduces if you take vaccine. There hasn't been any, I haven't seen any quantification about the data itself.
Okay, thank you. Please do ask any other questions as we're going through. Mary, you've got one, haven't you? We can't hear you, Mary. Can you unmute yourself?
That's it. Yeah, I've had a question from a lady whose husband is in Pakistan looking after his parents. He's had 2 vaccinations there, but she's asking, will he need vaccines when he comes here for them to be effective?
Okay, so I'm not sure what vaccine was it, but if it is a standard vaccine, then that should have the immunity grown partially. Now, obviously, they don't need to take a new vaccine because 2 doses is recommended. So when he comes in, he probably would be able to have depending on what group they are in, they would be able to get the booster vaccine, which is going to be delivered between September and November,
right,
or December rather. So I think I would say there hasn't been a clear guideline that if you had Pfizer, then you have to have a booster of a Pfizer, or you have to have a booster of an AstraZeneca and have a mix and match. So that's not being cleared by the Department of Health yet, but we are waiting for instructions.
Okay.
And it's important to see what vaccine they had taken, and if it is AstraZeneca, similar to there, or if it is Pakistan had been using one of the Chinese variants. So there had been some studies. Again, you have to sort of look at that and discuss that individually. But there hasn't been, we haven't been using that. So I think you probably would be able to get away with mix and match.
Okay, thank you. Yeah.
So you're expecting that in the autumn that they'll be rolling out a program of boosters for the vaccination?
There would be a rolling out of boosters, definitely. And there would be 2 phases, which we haven't got the details of the details of how we are going to deliver it, but at least we can say that in the first phase there would be under 70 and healthcare professionals would be getting the vaccine, and on the second phase there would be vaccination for vulnerable people who actually receives the flu vaccination, and all those from 50 to 70 would be vaccinated. There hasn't been any decision taken under 50s who is not having any health need, but otherwise everyone else would be having vaccine. And there is plan, actually. I have been in a meeting in the morning where there has been plans going on to how to deliver it and what support we need.
Great. Okay, we've got quite a few questions coming through now on the chat. A question about lateral flow tests. How accurate are these lateral flow tests, and how soon do they show you have COVID before symptoms appear?
Okay, as I mentioned that you can be asymptomatic and positive for lateral flow test or positive for COVID infection itself. Lateral flow test is on certain studies, it had been shown around 70% sensitive. We look at sensitivity and specificity. It has a reasonably good specificity, but sensitivity is around 70%. So we always say that lateral testing should not be used for a symptomatic person. Okay. So I want to sort of reiterate this, that it shouldn't be used for a symptomatic person. If you have symptoms, go for PCR test. That's going to be the gold standard. Again, there has been false negative for PCR testing also, because in that case, a clinical diagnosis would be there, but that's not so common. So you only use a lateral testing if you're asymptomatic. If you become symptomatic, you can do a lateral testing, and if you're positive, but if you're negative, still don't rely on that. Go for a PCR testing.
Okay, and you can just order those over the internet, or
you can order.
Yeah.
You can order through 119. You can register yourself, and you can order that the swab testing for PCR, and you can actually go for one of the testing sites also.
Brilliant, thank you. Another question here, and we've heard lots about things you can do or take to keep the virus at bay, and it's always difficult to know what's actually scientifically based and what is just myth. So are there any things that we can do? For example, eating lots of vitamin D or sunshine, will this help?
Okay, healthy lifestyle is going to help, and there is a common theory that if you are having lots of vitamin C, that would sort of protect you from flu and improve your immunity. But I wouldn't just fully rely on sunshine, and the sunshine doesn't kill the viruses. So we can't sort of say that sunshine is going to cure you. And I wouldn't just rely on vitamin C. But yeah, it's a part of your healthy habit. But I think you need to make sure that you are not, you are maintaining the social distancing as much as you can, and you are wearing mask. Because if you look at what actually is causing the spread, previously there was lots of talk going on about fomite transmission. That means that, okay, we speak, we sneeze, we talk, and then there is small droplets are coming onto the surface, and then you get that and you sort of touch that thing, and then you get that inside your respiratory tract and your eyes and mouth, and that was the main way of transmission initially thought of. But then there had been further deviation from that, because there had been lots of studies since being taken in account, and that's quite clearly showing that it is airborne. So the droplets are in the air, and if you are sneezing, you are coughing, you are actually talking or chatting with someone, it can spread through air. And I know I might be sounding a bit controversial, but there had been quite a few studies which had actually shown that if you are in a closed space, it's not to scare anyone, but if you're in a closed space, just maintaining social distancing might not be appropriate fully unless you have a very good air exchanging system in place, where you are actually exchanging the air at a certain interval. Because when we are seeing patients in our surgery, we need to make sure that there is a certain interval between the patients, or there is an exchange system going on, in which case the air is being cleaned out of the particular room, or there is a proper sort of window there. And that's very important. So I think the airborne thing, when it came up, it sort of supported the mask theory more, because if there had been studies again shown that if you are wearing a mask and somebody else is, depending on the surgical mask, again, there are different types of masks and respirators which actually prevents any particles coming in. Sorry, I'm sort of chatting quite a lot.
That's good, it's good.
But if you are looking at the masks, if you're looking at a simple surgical mask or a mask which is covering our face, what we are basically doing is that we are actually preventing the spit or the particles from coming out, stopping it coming out of our mouth. So if somebody is infected and they are using the mask, there is a significant drop in infecting other person or spreading the disease itself. And if two person is wearing the mask, then that significantly lowers further. In fact, actually it goes down to 3% chance of infectivity. Whereas if somebody else who is actually infected is not wearing the mask and the other person is wearing the mask, then there is only 30% chance of getting the prevention. So there is 70% chance of getting infection still.
Yeah. So is your recommendation in sort of inside spaces to make sure that the room is well ventilated and to encourage people to continue to wear face masks?
Where it's possible.
Yeah, where it's possible. Great, thank you.
I know that quite a few people can't wear masks and things like that.
Yes.
That's a risk assessment, and you have to sort of look at the risk benefit yourself and risk assess the situation.
Great. Okay, we've got another question here. This is on a different theme. Do you think that over 100,000 reports from women about unusual menstrual bleeding after having the vaccine is concerning? Secondly, a good enough reason not to get the vaccine, considering we do not know the long-term effects on fertility?
The report about we all have to realize that this vaccine is, if you are looking at a vaccine coming to the market, that takes about 5 to 10 years. But for obvious reason, there had been a push to get this vaccine sooner than what's the expected time we should be getting. So there are certain side effects which are coming. Now, I have not got any clear research data to say that it has been causing menstruation irregularities, but there had been quite a few reports. What you mentioned, I haven't seen anywhere that I think somebody was mentioning about how much, what value was it? Sorry, I'm just looking into the chat.
How many people were 100,000?
Okay, so I would be interested to actually get the reference where the 100,000 had been sort of mentioned.
Okay.
Because
so
I'm happy to sort of look into that.
Yeah.
Because I'm trying to update myself, and if we get that clear data and a controlled environment where there had been sort of 100,000 patients reported that yes, and they are actually valid reporting and what type of changes, then that would be a big study, and it would have been actually mentioned in the usual journals. But I'm not, again, there is so much of knowledge I can't claim that I know everything, but it would be interesting to know. Now, there had been some reports I have come across where patients had been having irregular periods for a short period of time, and there hasn't been any clear outcome where it has said that it has affected someone's fertility. So that's not been proven, that I can reassure that. Again, if something comes in future, obviously I can't say for that, but at the moment there is nothing there. And I think if somebody's asking me that having a bit of irregular period, is it enough to stop or not take the vaccine? I would say use your judgment. What you feel more critical, having COVID, and 1 in 4 can have long COVID and complications and get admitted to the hospital. If with the complications, if you have some health complications, that's going to be more difficult. So is that more troublesome, or a short period of irregular periods? If at all it happens, then is that more troublesome? And I think I can't say that, okay, it is good enough reason for not to take, it's your judgment. But if you ask me personally, obviously I'm not a female, I wouldn't be able to say what's the period like, but I wouldn't say that if I were there and if I would have that condition, then I probably would save myself by taking the vaccine and accept that there might be a short period where the irregularities might be there. But that's my judgment.
Thank you. What we do is that the person who asked the question, if you'd like to send that link to Meru, and perhaps Meru could then forward it to Dr Ganguli, and then he can have a look at it for his own interest. Thank you. Anne, would you like to, you got your hand up. Anne, please ask your question.
Do you mean me, Pauline? Anne?
Sorry, is it Pauline? Pauline,
Right.
Are you Pauline or Anne?
Either. I answer to either.
Okay, good.
I just wanted to ask Dr Ganguli. I contracted COVID last November, and in February this year, I had my first AstraZeneca vaccine. And it did make me very ill for 2 days. In fact, I thought I was starting with COVID all over again, but it passed off. And then a few weeks later, my specialist put me on immunosuppressants. And now I'm worried, should I have the second vaccine? I'm really worried about it.
Okay.
Because they said, the specialist said, if I get any sort of infection, I've got to report it right away because it could go nasty very quickly. But if I get side effects from my second vaccine, how will I know if it's a vaccine or if I'm starting with? I'm just really scared. I don't know what to do.
Okay, all right. I can't answer your individual question for yourself, but I would try to do a general answer for your question. First of all, we need to realize that when you are saying that you have an immune therapy, that means that that's actually, if somebody has an immune therapy, then that actually is dampening someone's immune system. So somebody can get more prone to develop the infection. What vaccine does is it works through your immune system, and it would sort of develop some response through your immune system, because as I mentioned, that it's actually having a mock, what I would say, mock fight going on in your body. And that's where you would get some response coming up. Now, I would suggest, and obviously depending on the specialist advice, it would vary, that depending on the particular disease condition and particular medication, if they recommend the same vaccine or a different vaccine, it would be depending on the specialist who is saying, or it would be depending on your doctor who is going to advise you accordingly, which would be best for you. But if you are taking the vaccine, I can reassure that that's not going to give you the COVID itself. That's one important point. So if you are not getting the COVID from the vaccine, then it would actually get some immune response in you.
Yeah.
So I wouldn't say that, I know you are scared about the side effects, but at least I would say that if somebody's immune system is low, then they are more prone to get the infection itself. And if they are getting some protection, that would be the best option for them.
Right, okay.
I know I'm unfortunately, I can't directly answer your question for yourself, but I'm trying to generalize the answer and giving you because you need to understand that what's the immune system dampening medications are doing. So they are not going to, if you get an infection, you're going to get an infection from COVID or any other viruses or any other bacteria or bugs. But the vaccine is not going to give you the infection.
Right, okay, thank you.
Thank you, Anne, for your question. And let's move on to another one. How long will I test positive for COVID after having it?
Okay. I don't think we have any clear answer for this, but there had been studies where, there had been instances where people in ITU who had been having prolonged infection has been positive for COVID up to 21 to 28 days also. So, but usually the period during which you are infective, you get a COVID positive test. So once you are asymptomatic, your body has fought it off, then you would have COVID negative test. So basically, if you're looking at, I'm looking at all our patients who get admitted to the hospital with a positive COVID test. Once they are discharged, they usually have a negative COVID test, which is usually within 7 days. But there has been instances, as I've mentioned, that some people who are in ITU had been having prolonged COVID positive because they were still infected and they had severe disease process going on at that time.
Okay, so it varies from person to person.
Yeah, I would say case to case it varies, but usually if you are recovering from the infection, you would be negative for COVID tests.
Right, okay, thank you.
But we don't routinely do any negative COVID test to prove someone is not infected.
Right.
If they're asymptomatic and they have maintained the isolation time, then that's fine.
Yeah, okay. Another question here about surgeries. Lots of surgeries have obviously had to put up sort of restrictions for patients accessing because of the risks. are you expecting that surgeries are going to sort of be more open as the restrictions are eased after 19th of July?
Okay, first of all, I would say that we need to realize why we have been maintaining this.
Yeah.
Okay. The message I want to give you all is that we want to keep you safe, and that's why we are doing it. If you think of, there had been still guideline ongoing for NHS premises to maintain proper distancing and mask usage. And we have been trying to minimize our patient footfall in the surgery. So we are asking them to wait outside and coming in so that one person can't get infected from other. And as I mentioned, that there had been 1 in 4 to 1 in 5 patients who are asymptomatic. So we don't know. Our health staff are doing lateral flow testing on a regular basis because we are asymptomatic. But who is coming through the door, we don't know that whether they are infective or not. And if you are sitting side by side, and then someone is actually spreading it and you end up having the infection, is going to be the last thing what we want from our point of view. And that's why everything has been done like that.
Yeah, understood.
So there hasn't been, if the case, the rate goes higher up, what we are expecting in so-called third wave, then it would be very difficult to take all these restrictions. And we are still waiting for our proper guidelines to come up from the government to say that, because I'm giving you a few simple examples. If one of our patients uses our toilet, we doctors or nurses have to clean it in a deep clean each time somebody's using it, because that's with your poo and wee, the virus spreads quite a lot.
Right.
So if that's there, and if we are opening it up fully, then who is going to monitor who's actually using our toilet and who is not?
Yeah, yeah.
It's as simple as that.
Yeah.
And then when we are looking at each person sitting on, we say that it's airborne, but still there is fomite there. And if somebody is actually using our facilities, if they're using and sitting in a chair, when they are off the chair, we have to wipe that. And that's why when we are seeing someone face to face, previously, we used to have a 10 minutes consultation. I know that's inadequate, but still we managed some or other. But now, after seeing someone face to face, we have to wipe clean all the surfaces that had been in touch. And as long as that's there, we have to sort of maintain the social distancing and all other precautions in NHS premises. If the situation comes and we are allowed that, okay, you don't have to do that, and you don't have to monitor your toilet, and you don't have to police it, that's fine. We are more than happy to sort of go back to normal. I know a lot of people are looking at that, and you can imagine that putting a mask on and putting a visor on top of that, and then having a PPE worn off on with the gloves is not the sort of convenient situation we are in. And I don't like that. But then again, you have to sort of save yourself, you have to save your patients, and you have to do the best for your patients.
Yeah. Okay, thank you. As you know, many people are beginning to think about returning to the office, having worked at home for like 16 months. Would you think it's a good idea for people to be wearing masks when they go back to work in the office?
I would say one thing. Obviously, again, I can't mention about individual individual offices or individual personal situation. But what I can say is that it's very important to risk assess. And if you are going to work in a particular place, your employer should be risk assessing. We have been continuing to work from our premises, and all our staff have been risk assessed on a regular basis. And we are maintaining situations in such a way that one can't get infection from others. And that's what's again, we can't say that they can't, but we are trying to minimize it. That's what's important there. Right. So if you are going back to work, or you have to go back to work, you have to make sure that your employer has done proper risk assessment, and whatever needs to be there, be it a barrier between two seats, be it change of position, be it not face-to-face, putting some air exchangers or air purifiers in the room, whatever needed. And there is some industrial regulations and there are some office regulations which the employers should be maintaining. And as long as that's being maintained, that's fine. But I think if you are working from home and you can actually work from home, you are saving carbon footprint anyway.
Yes,
so
true.
obviously your
issue.
obviously your electricity bill or your gas bill might go up, and that's not being taken in account, but you are probably saving and doing things better for your earth, for the earth.
Good.
But then again, it's a controversial thing.
Yes. Okay. Thank you. We've had somebody else join us. You're very welcome. Just to let you know, we're recording this. So if you're happy to be on the recording, then that's, we would love to see your face. But if you'd rather not be seen, then you can keep your camera off. But if you've got a question, please do put it into the chat and we can ask Dr. Ganguli your question. I've got a question actually for you. As you know, Dr. Ganguli, we've got lots of different faith groups within our community. It's quite a unique community, and lots of faith leaders, including myself right now, are thinking, what are we going to do after the 19th of July? Because in theory, we could just say we're dispensing of all the restrictions, the face masks, etc. But that doesn't seem to be very wise, and it doesn't really show that we are caring for our vulnerable members of our faith groups. So I've got a meeting later this week to talk about it with some of the other leaders. But I just wonder, what's your view? What would you say to faith groups in the community?
Yeah, again, it's a very difficult question. And I can't sort of say that one size fits for everything, for everyone.
General advice we're looking for.
I think again, the most important point is risk assessment. Do we think that the case is going down? Do we think that our rate is going down or it's going up? That's one important indication. The next point is that we need to encourage people to be safe themselves. And one of the important things, what I've said, because it's a airborne disease, we would need to encourage people to wear masks and maintain the distances. And obviously, when possible, not to come too close. And I think I would say that our faith leaders have a great role in encouraging our population because they have a very renowned position. So by using mask yourself and encouraging people to use it when they are looking at you and understanding that you are maintaining this prevention because that's what is appropriate, that would sort of probably encourage people to do that. But if somebody doesn't want to wear that, it's completely up to them, because obviously there is no legal restrictions and you can't enforce it in a communal area. But obviously, I think we have to be more responsible ourselves and take it so that we don't spread it further.
Yeah. That's helpful. Thank you. I'm making notes here. So that's helpful advice, general advice. If anyone else has any more questions, please do ask. There was one earlier that I want to pick up on. We hear every day on the news about the COVID levels. But where do these statistics come from?
Okay. I think if you look at all the cases who are being identified is in a central lab.
Yeah.
So all the PCR tests are being monitored.
Yeah.
So that's why it's quite sort of easy to identify what's the rate is. And it is not a straightforward data. And it's sometimes we are looking at rolling average on certain statistics. And our rate is sort of depending on that, the rate of spread. And it takes quite a few statistical data in account. But I think if the R rate is below 1, then that's safer, where R rate means actually in a simple term, if you look at the graph in a closed space or one person is infecting 2 or 3 person, and then that 3 person infecting another, each person infecting another 3. And so that's a reciprocal rate of increase of the disease itself. So if you are actually that reciprocal rate, you are dropping it down, then actually the rate goes down and it infects less and less people. So there is no reciprocal rise of the disease process. So it's all centrally monitored, and the rate of new cases are taken in account and the R rate is calculated. And we actually get all the results of our patients who did get their positive or negative results from their PCR in our surgery. And funnily enough, we actually see there is a rise or fall on positive cases when we are actually monitoring our patients. And that's corresponding. And I can say that this is, we looking at that, and then we correspond to look at and see, oh, the R rate is going high. Yes, I can see that today the number of cases are much higher.
Yeah, interesting. Well, I've learned a lot this evening. I'm sure others would feel the same. And we said we would grill you for 45 minutes, and you've done really well. But before we close, I think I've covered all the questions in the chat. Has anybody else got any other questions they would like to ask before we close our time? No? Well, thank you very much, Dr. Ganguli.
No, it's a pleasure.
Really, yeah, round of applause.
Thank you.